1.5 million men, 1 in 20, will undergo surgery for some sort of hernia repair. If your doctor has recommended an operation to correct this condition, you should know that now you have an option to traditional surgery. It's called a laparoscopic procedure, and the next few minutes you'll find out just why today, for many men, it's the preferred alternative. Hernias happen to men from all walks of life. There may be no outward symptoms, allowing many men to live with the hernia for years without any serious complications. However, without treatment, a hernia will not disappear. 80% of all hernias occur in the groin area, known as the inguinal region of the abdomen. The abdomen is a large sac containing internal organs. If an abnormal opening occurs, some of the organs may protrude. This protrusion, which can often be seen as well as felt, is known as an inguinal hernia. Men are about 10 times as likely as women to get an inguinal hernia. In the male, this condition occurs when a loop of the bowel passes through the inguinal opening, the passageway through which the male spermatic cord passes to the scrotum. Hernias usually are caused by weakening of the abdominal muscles with age, but in many cases, the opening has been widened as the result of the strain of improper lifting or even a violent coughing attack. This kind of strain or lifting can cause the muscle layer to give way suddenly, so that every time you strain or lift something, the abdominal contents push out through the opening or defect, making it even larger. This can occur on one side of the groin or both, referred to as a bilateral hernia. Some men will experience a dull, aching sensation in the lower abdomen, a sharp pain, or a vague feeling of fullness. When the intestines are involved, nausea and constipation may also accompany the hernia.
I understand you've got an inguinal hernia?
Well, I believe so.
Well, sit down. Let's talk about what a hernia is real quick. A hernia is a hole, if you will, that allows contents of one area of the body to go to another area in an abnormal location. For instance, in an inguinal hernia, which I suspect that you have, the contents intra-abdominally can go through a hole in the muscular wall of the abdomen and get into the inguinal canal down low. There's two ways of fixing that problem. We have a traditional open approach, and we have a laparoscopic approach to the problem. In the traditional open approach to fix an inguinal hernia, we actually make an incision in the groin down here. We go through the muscular layers of the abdominal wall, find the hernia and the sac that it's in, open the sac, return the contents back into the belly where they belong, and then we take the sac and cut it off, and then repair the abdominal wall on the way out in order to close that hole where those contents have come through. In most cases, we put a piece of mesh on top of that repair in order to give it more strength. If we do the repair laparoscopically, it's a completely different approach. If we do it laparoscopically, we place 3 trocars into the abdomen, which is a tube like this, and this hole allows us to put a camera in so that we can see where the hernia started from, and by putting 2 other trocars like this in, it allows us to put instruments inside, and using the camera and working off a video screen, we can open the sac of the abdomen, pull the hernia back inside along with its contents, and then we place a piece of mesh in, like this, through this trocar. As you can see, it slides in just like that. Then we position it over the hole where the hernia started, and we staple it in place with a device like this that actually fires staples through the mesh into some strong structures that surround that hernia defect, and we form a screen over it and prevent anything from going back out. After we have the mesh stapled in place, we then sew the covering of the abdominal wall back over the mesh to cover it back over. And that's basically the 2 different repairs.
Which one is better?
Well, what we need to talk about probably first is recurrence rate, because what you want to know is if I fix the hernia, is it going to come back?
Exactly.
Well, in the classic traditional open approach, the recurrence rate runs between 5 and 10%. That's if we make the incision and go in the old-fashioned way. In the laparoscopic series that have been published so far, the recurrence rate is running somewhere between 3 and 5%. So in most instances, it's about half of what it is in the anterior approach. Then we talk about advantages of return to activity and return to work. In a laparoscopic repair, most people are back to full activity in 1 to 2 days with minimal discomfort, and usually back to work in 4 to 5 days. If you do the classic open approach, the patient may not be able to go back to work for 7 to 10 days, and at that time limit, probably a reduced rate of activity, if you will, because there's limitations on the open approach because of cutting through all the layers of the abdominal wall. You can't lift anything over 30 to 50 pounds for about 6 weeks. So, whereas in the laparoscopic approach, your activity level is basically unlimited when you return to work because of the tiny 3 incisions versus the longer incision and the dissection through the muscular layers.
Complications in risk, Dr. Leggett, can you explain those a bit further?
Yes, any type of operation, whether it's done laparoscopically or open, has potential complications, i.e. bleeding, infection, recurrence rates, which we talked about, damage to nervous structures, or postoperative discomfort. The incidence of both, of all of those complications related to both the open and the laparoscopic repair are minimal, probably less than 1%. You can get some swelling in the groin area, if you will, with both types of procedures. I'll ask you to do a couple of things if I do it laparoscopically to reduce any swelling, one of which is to wear an athletic supporter for the first week while you're up and about and doing things. And the second is to sleep with a heating pad at night over the groin area to reduce any swelling that might occur. We usually schedule these as an outpatient. You come in, you go to sleep, we do the procedure, and you spend a couple hours in the recovery room. We put your athletic supporter on, give you some pain pills, and send you home. And I usually try to see everybody back in the office of around a week or 10 days post-operatively.
I think you've answered my questions.
Great.
Thank you so much.
You bet.